Good morning, good afternoon, good evening. I am Diana Mackay, and I would like to welcome you to this webinar on the impact of conflict on global health and vulnerable populations, jointly organized by Brown University's School of Public Health and the Institute for Global Health and Development at Aga Khan University. Aga Khan University and Brown enjoy an enduring partnership, with today's webinar being just one example of many collaborations. And in fact, as we get started into the discussion today, I will be posting in the chat some of the links of potential interest to those who would like to know more about the Brown AKU partnership. If you're looking for the foundations on which today's events build, look at these links. But before we get started, a word on logistics. Please note the session is being recorded and also live streamed on YouTube. The recording will be available within a few days on both Brown's and AKU's websites, and I'll post the links to those recordings in the chat shortly. We have had well over 500 people register for the webinar today, and I would like to acknowledge in particular the many students at both AKU and Brown who are with us and who are joining the cause to address the tough challenges that are being discussed today. I would also like to acknowledge the more seasoned members of the audience who can help lend the guidance of their experience. I'm going to invite all of you to connect with each other, and to do so, we have enabled the Zoom features that facilitate your involvement. First, please do make use of the chat function. I encourage you to introduce yourselves by name and organization. Please be sure to note that you can, using the drop-down menu in the chat box, send your comments to all panelists or preferably to all participants. And please do share your comments with all participants so that everyone can see your contributions. Also, feel free to continue engaging in the chat during the course of the webinar. Second, please make use of the Q&A function to pose questions that our moderator and speakers might want to address during the discussion. If you pose questions in the chat, we may not be able to see them as the chat goes by quickly with lots of engagement from all of you. So please be sure to post your questions for the panel in the Q&A function. Finally, during or following the webinar, you're always welcome to communicate with us by email, and I will post our contact information in the chat as well. For those of you who are interested, we are pleased to let you know that the webinar is recognized by the Accreditation Council for Continuing Medical Education, and for those requesting it, an e-certificate can be provided after the session. Now, without further ado, I would like to introduce the co-hosts for the webinar, Dean Ashish Jha of the School of Public Health at Brown University, and Dr. Zulfi Bhutta, the Distinguished Professor, University Professor and Director of the Institute for Global Health and Development at Aga Khan University. More detailed bios for both will be placed in the chat as well. Dean Jha is moderating the discussion, and so without further ado, Dean Jha, over to you.
Great. Thank you, Diana. And again, as Diana said, good morning to those of you in the US, and good afternoon to people in Europe and elsewhere in Middle East and elsewhere, and good evening to people in South Asia or wherever you're really joining from. Thank you for being part of this. So the goal for today's about 75-minute discussion is really to begin to lay out how conflict, which really takes many forms and has many underpinnings, affects and shapes health of populations. And it may seem on surface very simple, right? Well, conflict affects people. People get hurt in wars and other things, but the real effect of conflict, as much as those direct effects are real, the much broader effects are the ways they disrupt people's lives, the ways in which conflict disrupt health systems, and the impact is far more long-lived than we often think. We often think of it as, well, while the conflict is going on, there is a disruption and it's bad for health. But in fact, the effects are much more profound and far more long-lived than we often think. And those are some of the kinds of issues that we want to get into today. And in order to have that discussion, we really have pulled together what I think are four of the leading experts around the world. And I have to say, just on a side note, to be able to do this with Aga Khan University and to do it with my friend Zulfi Bhutta is really an honor, because Zulfi has been doing some of the really best work in thinking about some of these issues. But let me say very brief remarks about all four of the panelists. They are all incredibly distinguished and have long bios, which I'm not going to read. I'm going to give you sort of a two-liner on each of them. And then then the way this will work is I'll ask each of them to speak for about 3 to 5 minutes. And then after that, we'll have a moderated discussion. So the first person who's going to speak today is going to be Paul Wise. And Professor Wise is the Berman Professor of Child Health and Society and Professor of Pediatrics at Stanford Medical School, and has done really some of the most important epidemiologic work looking at the impact of conflict on civilians, on maternal and child health, and has been one of the key people on the behalf of the US government also, one of the key people looking at what's happening on the US border. So we often think of these issues as somehow global, like out there. All of these issues also play out here in the United States. And Paul has been on the front lines really trying to understand how what's happening on the US border with Mexico is affecting the health of children. And so my hope is that we'll be able to weave some of that into our conversation. After Paul will be Mike Van Rooyen. Mike is a professor at the Harvard Chan School. He's the director of the Harvard Humanitarian Initiative. He's an emergency room physician and chair of emergency medicine. But what Mike and the Harvard Humanitarian Initiative has done that I think has been most remarkable has been about really trying to bring science to humanitarian response. Humanitarian response has often been seen as this thing that there's a horrible outcome somewhere, there's a conflict, and then people just rush in to try to be helpful, which is really good and it's great and it's motivated by the right things. But what HHI has done under Mike's leadership is to say, how do we bring evidence and science to how we respond, and how to make sure that our response is effective, that it's sustainable, that it really has long-term impact. And I think that's extraordinarily important, and it'll be really great to hear from Mike's perspective today. After Mike will be Stephanie Friedoph. Stephanie is a professor of the practice here at the Brown School of Public Health, is a journalist, has covered conflict in several different continents, and has really, her work that I think has been most important, not most important, but certainly very important in the short run, in recent times, has been the issue around information, misinformation, and how that worsens health outcomes in the context of conflicts. That conflicts create this sort of this vacuum for information, and that vacuum gets filled in. And what some of the work that I think Professor Friedoph has been doing has really been helping us understand and think about where does that information come, how does it get filled in, and what health impact does it really have on people. And then last but certainly not least, it will be Zulfi Bhutta. As I mentioned, I've first met Zulfi, I don't know, about a decade ago or so at the World Health Organization. We were on a panel together. He is the director of the Institute for Global Health and Development at Aga Khan University, and has done really, as I said, some of the seminal work looking at things that impact child survival, maternal and child undernutrition, micronutrient deficiencies, and how they impact health and well-being, and has been a really terrific leader in this space. And so this is going to be a great discussion, and I'm going to stop talking because I want to actually turn it over to our panelists, and I'm going to start off first with Paul Wise. And I will just give a little extra shout out to Paul because it is about 6 in the morning out on the West Coast. And so anybody who's willing to get up and look as good as Paul does at 6 in the morning deserves a little extra praise. But Professor Wise, over to you.
Thanks so much, Ashish. It's a privilege to participate in this important discussion. So I'm happy to get up whatever time is required. My basic point is that the reality of humanitarian health will always need to respond to the reality of violent conflict. That this reality of conflict is also important to recognize as intensely dynamic. And it is essential that humanitarian strategies respond to this dynamic reality, and perhaps more importantly, anticipate both the obstacles and opportunities for humanitarian protection and service provision in settings of violent conflict around the world. Now, much of my comments are really the product of the branch consortium. It's a remarkable collaborative led by Zulfi Bhutta, a collaborative of universities, humanitarian agencies, and NGOs, and leaders from affected communities around the world. It's a collaborative dedicated to developing new knowledge and new strategies to address the humanitarian protections and service needs of women and children in areas plagued by violent conflict. Almost 80 million people are currently displaced by violent conflict around the world. Almost half of all children live in countries affected by violent conflict. Conflict countries have been falling behind other countries in meeting the Sustainable Development Goals, such that global child health is fast becoming global child health in conflict. Now, some of the important elements of this dynamic reality I can mention briefly to provoke discussion that we can continue as the morning moves on. First is confronting urban combat and the use of explosive weapons in densely populated areas. This is not new, of course, but what is new is the attempt to provide humanitarian protections and services in the midst of urban combat, in the midst of siege strategies intended to deprive populations of the essentials of life. Most wars currently are proxy wars in which local fighters are being backed by regional or global powers with enormous financial capabilities as well as sophisticated technology, which creates hybrid wars where social media misinformation is connected to kinetic activities on the ground. Also, criminality has undergone important changes in these conflict settings. It doesn't take money to start a war, but it does take money to win a war. And virtually all the conflicts in the world today are heavily interactive with illicit economies and criminal activities. The traditional dichotomy between grievance and greed has been blurred, such that virtually all these conflicts and virtually all the combatant groups are engaged in some level of illicit economies and criminality, which can make the dangers for humanitarian workers and health workers in these areas ever more profound. We also need to think about large-scale combat operations, great power conflict. Much of the humanitarian world has been focused on counterinsurgency conflicts, civil wars, but the militaries, particularly NATO and US militaries, have pivoted to great power conflict and large-scale combat operations. And the humanitarian world will need to quickly respond to the potential for these type of violent outbreaks in ways that could generate a scale and nature of humanitarian requirements that we haven't seen for decades. We also ultimately need to recognize the impact on humanitarian norms of shifts in geopolitical power as Russia and China exert new capabilities. The implications for humanitarian norms and protections will need to be addressed, followed, and ultimately responded to. The suggestion basically is that as violent conflict evolves, so too must our humanitarian strategies. Thank you.
Great, Paul, thank you so much. I'm gonna go next to Mike.
Thank you, Ashish, and the panelists, thank you. It's a distinguished group, and I'm really proud and pleased to be part of this discussion. I'll give you an anecdote, actually, to start us off that will be very local. But a couple of days ago, I was working in the emergency department. I'm an ER doc, and I saw a patient that was hit by a car at a relatively high speed, a pedestrian. The patient was badly injured, and we have a trauma system that took care of that trauma patient, and I was there caring for that patient. But it occurred to me that actually the parallels to this discussion about war, conflict, and population vulnerability are very, very similar to the vulnerability of this patient. In other words, if this was a 20-year-old versus a 70-year-old, the vulnerabilities of that patient would be quite different, and the outcomes would be different. If the car was going 5 miles an hour versus 50 miles an hour, the injuries would be quite different. And if we had a team that was less well equipped, the outcomes would be quite different. And so I want to use this as a bit of a touch point or an analogy to the way we think of conflict. Conflict accomplishes many profound impacts on people's families and populations, and Paul mentioned several of those in the way that conflict is changing. We know that large-scale conflict and disaster disproportionately affects vulnerable populations. It's not a mistake, or it's not an accident that very vulnerable populations suffer disproportionately due to large-scale disaster or conflict, and those with means, with wealth, with health actually do far better. We also know that war and conflict create major obstructions to aid and complexities in aid, like access, difficulty mobilizing resources or gaining access to populations. And finally, we know that the impact of conflict is long lasting. It's not just a traumatic episode. It's actually the deprivation of resources for families and communities that last not only during conflict, but for many years. And essentially, large-scale disaster and conflict are the definitive de-developers. They underdevelop or cause gross de-development and underdevelopment and obstruct future development. So what do we learn from current humanitarian emergencies that are ongoing that allow us to understand population vulnerability, effective responses, and the future of aid in Syria, Yemen, DRC, Sudan, CAR, Somalia, Tigray, as well as things like the COVID epidemic? Like, how are all of those conflicts and phenomenon driven to help us understand aid? So in a couple minutes, I want to move from macro to sort of field level. On the macro level, there's certain things that drive vulnerability, just like my patient that gets struck by a car has baseline vulnerabilities like cancer or heart disease or other things, right? Global population trends matter because global population trends and poverty concentration are not spread across the world equally. Actually, they're very much concentrated particularly in the MENA region, right? The Middle East, North African region. Also looking at climate insecurity and water competition. So climate insecurity and climate change is affecting populations across the world, but it disproportionately affects populations that have limited means of coping, causing migration, populations moving on top of each other, urbanization, etc. Water competition and food insecurity also exacerbate migration. If you laid a map on top of each other of global poverty concentration and high fertility rates and climate insecurity and water competition and food insecurity and predilection to migration, it looks like a heat map of the Central African and Middle East, North African region, right? We know where we're going to be working in the next, with some exceptions, in some areas of exception, those are going to be areas that have the greatest concentration of humanitarian aid. Add to that the notion of political disruption and state fragility, right? So if you have not only those issues which precipitate state fragility, but also lead to more conflict, more as Paul said, interstate conflict or intrastates. In other words, non-state armed actors working within a community. They're more buried deeply within communities, causing community vulnerability as well. So all of those things lead to compounding vulnerabilities. Now, what's our response to that? Well, first of all, the aid world has to respond to this changing architecture and this changing structure by actually retooling what we do. Part of aid and access restrictions have forced us to accomplish localization. In other words, advancing the local capacity of organizations to do a better job of doing aid themselves rather than the Western intervention that has been traditional. Some of us are describing this as decolonizing aid. How do we decolonize or change the paradigm of funding and the ways that we are funding and putting priorities on aid, so it's driven by national structures and countries themselves. how do we actually help organizations take that humanitarian relief that happens in the emergency relief and translate that into longer term development and peace building? We call that the Nexus, the Humanitarian Development Peace Nexus. How do we look at programs that actually empower individuals locally? You know, there's a big movement accelerated by COVID actually on cash and direct to recipient cash transfers. So it takes the middleman out, right? It takes the aid organizations out of the mix as well. How do we encourage countries in the global South to support each other in South-South triangular cooperation? And then how do we invest in organizations both locally and globally in better leadership, better innovation, better use of ICT, better use of technology to adapt to these changing vulnerabilities that we see globally? So I'll just end with, I think that the aid world, in my experience, has been enforced to be very nimble in its approaches, but I think that we have a long way to go and to try to localize aid and to address these fragilities. So thank you.
Great, Mike, thank you. In that context of thinking about the vulnerability of the population at the heart of how we think about the response to conflict is super important. I'm going to turn now to Stephanie Friedoph, and Stephanie, over to you.
Thank you so much. Oops. Thank you so much, Ashish, and thank you everybody, to my co-panelists for the insightful comments so far. Thanks for having me for this important conversation. And also thanks to all the participants. It's wonderful. Please keep posting your names and affiliations. It's terrific to see how many people are joining us and are caring about this topic today. I wanted to spend a little bit of time on an overlooked thread in all of this, a challenge that has made surviving in conflict zones all the harder, and that is troublesome also for humanitarian aid organizations and anyone else really who works to alleviate suffering in conflict zones. And that is the threat of weaponized misinformation. Or if we use Paul's framework that he just laid out, it's a reality that we should have, but didn't anticipate. Imagine you live in a conflict zone or you're fleeing from your home because of conflict in your region and food is in short supply, and a friend shared on WhatsApp about a humanitarian aid group giving food out near a town center. Do you trust it, or might it be misinformation to lure you out? What about a recent Instagram post saying that all the foreign aid workers are bringing COVID-19 to town and that you should stay away from them? Or what about a TikTok video your cousin showed about how healthcare workers in a nearby health clinic say they're vaccinating people against COVID-19, but in truth, the video says they're injecting microchips so they can keep track of you wherever you are. These are not made up examples, and there are many more of them. In conflict zones around the world, misinformation is linked to violence, mistrust, social disturbances, and targeted attacks on healthcare providers. We've seen this in 2014 in the Ebola outbreak in Guinea and other West African nations. We've seen it in 2019 in the DRC, in the more recent Ebola outbreak. And just in the first 2 months of the current pandemic, the IRC counted over 200 attacks on healthcare workers around the world, mostly in fragile states, related to COVID-19. There's so many examples. In Syria, the Assad regime is blaming COVID-19 on Americans and is confusing people about how the virus works and how they can keep themselves healthy. In the Ukraine, Russia has promoted anti-vax messaging for quite some time and is undermining trust in government and health systems. There's been a recent attack on a bus full of Chinese evacuees because of a fake leaked email campaign pretending they were bringing COVID-19 to town. So we live in this era of weaponized misinformation, and these campaigns spread quickly across social media and from social media into offline conversations in communities. The WHO has coined misinformation campaigns about COVID-19 an infodemic. And this infodemic has become a major obstacle to vaccinating the most vulnerable populations in these fragile environments. And we've heard from Mike and Paul that conflict is changing, and misinformation is one of the drivers of that change. Information wars are real, and we want to add them really to Mike's fantastic heat map that he's just laid out for us. I think you all are, or most of you are probably aware of the many memes and videos and popular narratives that we see about COVID-19 doesn't exist at all. It's a ploy to allow authorities to embezzle public health funds. And studies show that people who believe such misinformation are much, much less likely to get a vaccine or to initiate other behaviors that support health. So it's unsurprising that lack of confidence and interest in vaccines is high among refugees around the world. So we talk a lot in Western nations about the threat of misinformation, and that's of course important, but we do fairly little to understand and mitigate how it plays out in devastating and accelerated ways in conflict regions, where people don't have the luxury of time, trust, and verification. If you wait to see if that food source at the town center is legitimate, and if aid workers will make you sick or not, that's a costly decision if you otherwise go hungry. Not getting vaccinated because it's impossible to know who to trust makes the vulnerable all the more vulnerable. Humanitarian aid organizations have really started to sound the alarm and understanding that just like the fog of war, the fog of information really has dramatic consequences. But just like everyone else, they're finding that misinformation can be an overwhelming threat. It's hard to deal with. With today's technology, it's so easy to produce false content. Really, all you need is a phone to make a video clip or a meme, and then you can spread it. But it can feel so hard to disarm and counter such things, especially for those untrained in how our modern information ecosystem works, untrained in digital marketing or in the tactics of misinformation. So I wanted to use my time today to make a bit of a plea that it's overdue for us to invest in a better understanding of how misinformation plays out in these contexts and in training more and more people in how to disarm it. The Mercy Corps has done a fantastic job, for example, training 15,000 community messengers to help combat misinformation in villages in Liberia. They and others are piloting rumor trackers where people can input misinformation that they see so everybody can come together to respond to it. There's other fantastic examples and technologies that are being developed, and we should use them. We should know more, we should understand better these challenges, and we should start investing in really addressing them. And to end or borrow one another of Paul's phrases, it doesn't take much money to start an information war, but it does take investment and money to win it.
Great, Stephanie, thank you for that really important perspective. I mean, the issues around how we support people in moments of conflict are hard enough under the best of circumstances. And technology has been a great enabler in so many ways, but it has also been a huge detractor. And we've got to figure out, since we're not putting this genie back in the bottle, we've got to figure out how to manage it much more effectively. Let me turn it over to our cleanup batter, to use a baseball analogy, Zulfi Bhutta. Zulfi, to you, sir.
Thank you. To many people in our part of the world, that would be either the 11th man or the 12th man, or somebody who's just been sent, as in the cricket analogy, to be the night watchman. You know, I'm thrilled and delighted to be part of this conversation and with the colleagues who have highlighted such important issues in the context of conflict, fragility. I want to step back and once again highlight as to why I got personally involved in this and to bring back to the reality of conflict in some settings of the world. So we estimated that close to 10 million children died between 1995 and 2015 in a decade because of the direct and indirect effects of conflict. And this was all before COVID. And we had an enormous challenge in trying to convince people of the indirect effects of conflict, because most of the time the information that we have available from any conflict settings and emergencies is on measures of direct mortality, battle-related deaths, which only capture the tip of the iceberg. And it took a pandemic like COVID-19 to bring home the reality that some of the indirect consequences of loss of services, of people not being able to go and seek simple things like antenatal care, immunizations, of closure of essential hospital facilities. All of those have consequences that can have a huge secondary impact on health, survival, and well-being. So I don't have to convince people today that conflict has both a direct and indirect effect, and we grossly underestimate the impact of conflict by just focusing on mortality. To give you another simple stat, in the global context, we estimate that close to around between 650 and 700 million women and children live within 50 kilometers of the epicenter of conflict. Now just think about that for a minute. Now, those are people who are just directly vulnerable to the direct effects of conflict per se. But when you go beyond as far out as 100 or 150 kilometers, that figure multiplies enormously. So if you look at the ripple effect of conflict in various geographies, particularly as people would note with many of these never-ending wars or forever wars, I mean, those ripple effects are quite enormous. So I want to focus a little bit on not the depressing scenarios that we have today of the overlap that Mike was talking about, of vulnerability, poverty, climate change, conflict, deprivation, and talk a little bit about solutions. What is it that we can do today with the limitations that we have, both of resources, human resources? And fortunately, our branch consortium, when it focused its attention on this topic over several years, was able to come up with not only a framework, but good examples of how resilience is so important, that how people have been able to find local solutions well before even decolonization became a buzzword. And those relate to the fact that many of the local groups and NGOs on the ground, national small groups of people, do find ways around many challenges with local solutions. So there are things that we have recommended as part of our work, which is working through task shifting, that you could work through community health workers where physicians don't exist in adequate numbers in primary care settings. They may only exist within hospitals. And those have been found to be very useful strategies in addressing maternal child health and survival, even in non-conflict settings. And their utility in conflict and insecure settings is quite considerable. And now there are practical examples through rigorous evaluations, including cluster randomized trials that our group has done in the middle of conflict with Taliban, that shows that those can be effective strategies for reaching people. The other thing that it does when you have local players is that it does build greater confidence in terms of community dialogue and engagement. So what Stephanie was talking about, disinformation and lack of trust, the one real way of rebuilding that is through engaging local champions, local people, people who have their roots firmly planted within the same context and geography that you're working in. And to some extent, Ashish, that is what is probably needed in the response to the disinformation here in North America around some of the COVID-19 and vaccination. So there are lessons that one can learn from some of those examples, and the examples that I know best with personal experience of is from the Afghanistan-Pakistan region, where in the border areas, some of these conflicts have been going on for almost 4 decades. I mean, I began some of my earliest clinical experience as a pediatrician in refugee camps with the people coming in from Afghanistan. And today, as we look at that scenario, it's been one of the longest ongoing conflicts in the world, which has not only led to an enormous number of deaths, but it has changed the lives of generations. I wrote a piece some time ago, which was called Children of War. And you can only really understand that when you look at children in parts of the world like Afghanistan, like Palestine, who have actually seen and known nothing but conflict and insecurity throughout their life. So why I raise this is that as we look at our repertoire of interventions to save lives, it's also becoming very clear that we need to do a lot better in terms of addressing some of the morbidity, the toxic stress, the early exposures, and bringing within our repertoire of interventions better, more evidence-informed interventions to address some of the mental health challenges, some of the issues around developmental trajectories, linking health with education. So the multisectorality of all of this in the context of response. And again, to underscore, this is not news to people anymore because we have experienced exactly the same within the recent pandemic. So let me close by saying that while the figures look startling, while the situation looks grim, and the challenges look very daunting, we believe that we have enough examples from our in-country work and from some of the global evidence synthesis that there are solutions. And there is, for every problem, a context where people have been able to find some solutions that have worked and have led to some mitigation strategies. The last point I would make, Ashish, is around COVID-19. I think we currently have a major global gap, and it's something that you may want to highlight in one of the opportunities that you get. If you look at a global COVID map, it looks as if the countries with the least prevalence or least burden are the conflict countries. And that's a perverse logic, because that's the place where you have the least information, you have the least testing, you have the least equity in terms of who has access to all of those investigations. So that's not necessarily the truth. The truth is we know very little about what this pandemic has done to many of those geographies. And from the little that I know from work in Pakistan, Afghanistan border areas, that the pandemic is alive and well in many of those areas, may not have the same intensity as urban populations, but we need to probably do a better job in terms of vaccinating people in those places because they currently have no voice. Thank you.
Great, Zulfi, thank you. And you anticipated the question I was going to launch with, so I will launch with it anyway. But I'll start with Paul and see if others also want to comment. And in general, I'll just try to. There are questions coming into the Q&A, so I'll grab them and maybe direct them to individuals. But I do want to start at a bit more broad of a lens, which is this issue of, this is a conversation we could have been having and should have been having and have been having for a while, but we could have been having it 2 years ago. The one big difference between the conversation we would have had 2 years ago and now is we're going through a global pandemic, which surely exacerbates and highlights a whole set of these issues. And so I was wondering, and maybe I will begin with Paul, because you mentioned the number that I often quote of 70 to 80 million people displaced around the world right now, a number that's the highest it's ever been since the end of World War II. And the effects of conflicts are many, but certainly one of them is that it causes substantial displacement. And I wonder, Paul, if you can begin, and then I'll see if others want to chime in on how the pandemic is affecting displaced populations. What do we know? What do we not know? And Zulfi did get into this a little bit, so we'll come back to that. But I just wanted your perspective. And also, Paul, when we think about what has happened over the last year or so at the US border with people coming in, how has the pandemic affected that, shaped that as well? So if you don't mind just starting there, and then we'll go to others.
Great, thank you. Well, what is very important to recognize is that just like conflict, pandemics have both direct and indirect effects. The direct effects is getting sick and potentially dying from the disease. And we know that there are many areas affected by conflict where COVID has exacted a terrible toll in direct effects. And as Zulfi mentioned, many of these are invisible to the Western world because of a lack of information. But there are also indirect effects that shutdowns, changes to transportation hubs, markets, local markets, regional markets have been dramatically altered such that incomes, livelihoods have been destroyed in places where livelihoods are extremely fragile. So there are both direct and indirect effects. And those indirect effects particularly are forcing people to move, forcing people in desperation to move to new places. There's another factor that's also going on, and that reflects the collision between COVID and the exercise of power, that COVID has influenced the ability of states to govern effectively. And what we see in many areas affected by violence is that armed non-state actors, combatant groups, and criminal organizations have actually taken control of providing anti-COVID precautions, enforcing lockdowns, handing out masks and foods, in many ways to enhance their legitimacy as government presence evaporates in the face of COVID. And these power relationships are quite dynamic in these areas and also reshaping the conditions under which people on the edge have to live, including moving to the US-Mexican border. COVID has deeply affected the ability of Central American communities to exist, to survive. It's disrupted the fabric of community life as well as livelihoods and pushed people to move. Despite much of the rhetoric, there's very little evidence that migrant families, children are a threat coming across the border in terms of COVID. Their movement through Mexico, living in stash houses on the Mexican side of the border for weeks before they are moved across the border, has also enhanced transmission of COVID dramatically. And we know now, particularly among kids and families, about how much COVID prevalence there is in these families, and it's somewhat less or approximates the general public in the border communities. However, their exposure in detention facilities remains a deep concern.
Thank you. Mike, how have you seen the COVID pandemic shape the way you think about it? I mean, you talked about a little bit about kind of localization of support, how it's changing the aid world. What are other things that you see as impacts of COVID in what you think you'll be doing in 5 years and 10 years, what your organization will be doing, but really what this whole field will look like? What's going to be different because of COVID?
Yeah, thank you. Just a comment on Paul's note, the vulnerabilities of migratory populations are not just on those populations, but also on their host communities. So even though migration is global, it actually is most densely local or peri-local, meaning that the strain of populations that are on host governments near them, like in Lebanon, for example, really derail and disrupt those communities as well, and make them more prone to the effects of the epidemic. As to your question, I think there's significant side effects and actually some benefits to the COVID epidemic. The side effect is just it's really restricted travel, and organizations can't get in the field as much. They can't cross borders because of restrictions and safety and security that's always been there. And now with this additional layer, it's just difficult to move around globally and get work done. It's forced us, however, as an aid agency or aid industry to really look at ways to accelerate localization, very much like, we're Zooming more now, and maybe in the future we're not going to go back to normal, right? We're going to be Zooming and doing other work in a little bit of a different way. I think the aid world is going to have to do work in a different way. And that is going to be to really accelerate leadership development, local organizational development, shifting the paradigm of who gets funded and how they decide to spend funding. And then this whole issue of cash and direct to recipient aid has always been important, but it's even more important now. And so I think, and that's an innovation, actually. That's a really important innovation that will come out of this. So I think our roles will be different. The fluency in access will be different, but also those accommodations, I think, are going to be important and useful.
Great. And if, right, there are a few fleeting not even fleeting, but silver linings coming out of this horrible pandemic. And if one of them is a set of stuff that you're describing around localization, building up real leadership and capacity and resources, that will clearly be a good thing. Stephanie, I'm going to turn to you next, and you brought up several examples of misinformation in the context of the pandemic. Do you see the pandemic accelerating, changing, in any way really kind of affecting the misinformation landscape? Because again, if we were having this conversation 2 years ago, you could have told a lot of the same stories of how misinformation is really starting to take root in places where there is information vacuum and in the context of conflicts. Has the pandemic changed that in any meaningful way, or has it just accelerated it, made it more prominent? How do you see the intersection between pandemic, conflicts, and misinformation?
Yeah, thank you, Ashish. I do think that the pandemic has significantly not just accelerated, but made visible to more people the impact of how we communicate and how people receive their information. There are many more examples, and specifically, I think we're also better understanding there's always been obviously geopolitical information warfare, but we do understand a lot better how this is done online now. We understand how information is weaponized and spread through different platforms in a very micro-targeted way to impact to confuse people, obviously, and then to impact their behavior and choices.
All right, I'm gonna actually go to the questions that came in. Thank you for that. And I'm gonna start actually with Zulfi. And but there's a broader question here, which is one of the people in the question asks about the Afghanistan-Pakistan border, and one of the reasons why polio has not been completely eradicated from these regions is because community health workers, which we talked about, are also terrorized and face threats to their lives. And so how do we deal with violent and political forces that directly target the health workers? And by the way, obviously not just a feature in any way of just the Afghanistan-Pakistan border area. We've seen an increasing targeting of healthcare workers. But if you, Zulfi, could get us just going on that conversation, because I do want to talk and have other panelists step in as well to talk about this feature, which feels new to me, and maybe it's not new, but this feels new to me, the more direct targeting of people who are there to potentially help. But Zulfi, to you first on how you see this issue.
So there is absolutely a broader question, and that is, why are we beginning to see targeting of health workers and also health facilities? I mean, which have been sacrosanct so far. And the simple, unfortunate answer to that is because it's effective. It's effective in terrorizing people. It's effective in sending messages. And at times when you have these facilities in places where they are the only places to seek support or relief, that's one sure way of getting people out of that area. So there are a whole dimensions to it. In the context of Afghanistan, Pakistan, which are basically populations that are not going anywhere. They live in very remote areas and mountains, and there the consequence of some of this disinformation, and also a lack of engagement around fundamentals. True to the questioner, one has to only do an analysis as to the universality of this phenomena to get an answer. And you find, as many of us have, that for every area where you have that insecurity and episodes of female health workers being attacked, you have equivalent or even worse areas where this is not the case. And the difference in both is very simple, is that you have a measure of community buy-in, community engagement and awareness. And in most areas of Khyber Pakhtunkhwa, or the previous federal tribal areas now called the newly merged districts, there is an honor code. If the community leaders and community owns a program and is engaged in it, they will provide its support. So I'll give you one example. The cluster randomized trial that I talked about was a very simple trial that we did in several areas of Pakistan, and the one that I will mention is Bajor, which is a very heavily conflict-affected, Taliban-controlled district. And the simple hypothesis there was, could we develop an intervention with community engagement and the rollout of interventions to address more than polio, but routine immunization and health services with community engagement that might make a difference. We didn't know at that time that it would. And this cluster randomized trial showed that if you did that in that area, not only were you allowed to work, but you were allowed to work effectively. We had to keep some of our camps open till late when we had no facilities, for no electricity, so we had to make emergency provisions because there was so much demand. So I think community engagement and working with community members, volunteers, and people who actually represent those, I wouldn't say gatekeepers, but influential people locally, is one key way of addressing this. And fortunately, as we speak, this polio epidemic in the region, which had exacerbated the last 2 or 3 years, seems to have come down quite dramatically. Because one of the things that has happened is very quietly, as Mike was mentioning, because people could not travel from the outside, all of these programs had to depend upon local folks and people on the ground. And lo and behold, they did a great job. And they are principally now telling people the simple truth that we should have learned years ago, is that entrust the local community, empower them, work with them, and importantly, work with the women, the young women and girls of those areas, because more often than not, they are the subtle opinion makers and holders in that community. To get to them, you may have to go through a few hoops, but once you are in the community, they are the people who make the difference.
So I want to see if anybody else wants to add anything to this conversation about the targeting of aid and health workers. Sounds like, Mike, you do, so please.
Yeah, sorry. I think this is a really important issue, and it's been going on actually and escalating for some years, since the hunt for Osama bin Laden and the CIA-backed campaign that used public health as a way to try to identify him. And it was exposed. That led actually to the direct assassination of and killing of immunization workers in Pakistan. So that was a gross and stark example of cause and effect. But even throughout the Syria conflict, which is going on, raging for many years, we've seen actually escalated levels of attacks, as has been said, on the white helmets or healthcare institutions or physicians or nurses or others. It's really a perpetual and increasing erosion of humanitarian neutrality. And the sense that somebody that is a humanitarian can actually be neutral is eroded for political purposes, for control of populations, and from a variety of perspectives. So as you said earlier, Ashish, the genie is out of the bottle with this one as well. And so now it's just trying to find ways to support this notion of separation of humanitarian activity from political will or political action.
Great. I don't know if Paul or Stephanie have anything. Let me maybe shift gears to another question about the fog of misinformation that Stephanie brought up, and I'll start there with you, Stephanie, and see if other people have thoughts as well. But the question is, in lifting the fog of misinformation, who will listen? And really, the question is, this person talks about the previous president of the United States and the issues around misinformation versus fact-checking. And fact-checking as a tool for fighting misinformation feels quaint and ineffective. This is not true. Well, so if fact-checking is not the antidote to misinformation, what is? And how do you, when I think about Mike's heat maps, in my mind, I kind of, the visual I have, and thinking about vulnerability, how do you build resilience to misinformation in communities, but particularly communities traumatized by conflict? So Stephanie, more thoughts on solutions around dealing with the fog of misinformation.
Thank you, Ashish. You've given me the small questions to answer.
Yeah, though this is the easy one. Just if you cannot take care of that, then we'll move on to the other stuff.
Let's do a little bit of framing. So it's important to understand that facts are an important part, but as you say, right, not the whole story when it comes to misinformation. People, like, why do we believe misinformation? It's because it comes from people we trust. It is because it plays to things that we believe to be true. It plays to our emotions. It fits the narrative. There's many, many different motivations. And facts are not always the best way to penetrate this, our sort of biased information-seeking behavior. A couple of so what Sufi has laid out is really important, because most of the solutions here are also local. As human beings, we trust the people around us the most. They live in the same environment. They face the same struggles often. So, the example was really great, that you want to integrate the communications efforts also don't need to be separate, or they shouldn't and can't be separate. They need to be part of the bigger picture of the intervention. There's another question in the chat, and I'll just merge these together because it's also about what can we do, or how do we all engage in this a little bit. And the shift in our framing needs to be that we all need to think about this more like the environment. If you walk along your river, right, and you see some trash, you pick it up and you put it in a trash can, and you want to do the same in online spaces. If you see misinformation, you want to call it out. It doesn't matter where you are. Another really big part of the solution is that we need to train many more people. We need to train everybody, but everybody needs to have a little bit of misinformation resilience, but also understand there's simple tools for verification. Right, one of the questions in the chat is like, how do we know what to trust? It's very easy to take an image and put it into reverse Google image search to see where else it has been used, right? And as Mike was saying, there was this moment when in Pakistan, right, when for the first time health efforts were used in the political wars or in the geopolitics of this. The same happened around the same time, or in 2012 in the Arab Spring, when images for the first time were being used to weaponize, where people were, starting to really invent these tools of fake and misinformation. But so that means we had a decade and we have developed the tools, but most people don't know them and they don't use them, right? So aid workers have ways to verify information, and they need to understand, like, it's not a complicated training, you can do that. So those are some of the components that we can use, right? It is empower communities, understand that it's not just about facts. The facts come like at the third or fourth step when you've built a relationship. It's important not to try to win over an argument. It's important, right? There's something called motivational interviewing that every aid worker should know, which is about listening and letting people talk. So there's a whole suite or toolkit of solutions out there, and we need to make them accessible and provide them.
Great. I don't know if anybody else, I would love to hear if anybody else has thoughts about how to really think about misinformation. I love your, like, it's about trust, belief, and emotions much more than it is about facts, who you trust, what your beliefs are, and things that appeal to emotions. And by the way, I want to make a point that I think is really important that I've learned from you, Stephanie, which is we always sort of think about this as like, these are the vulnerabilities of people out there. Like, no, these are the vulnerabilities of all of us. All of us believe things because it plays into our belief structure, because we trust certain people, and because they appeal to our emotions. And those are fundamentally human problems. And maybe people become more vulnerable in a place of conflict because a lot of their regular societal structures have been disrupted. But those are really appealing to the core of this. Paul, I see you unmuted. Do you want to jump in here?
Yeah, just quickly, I think it's important to recognize that information, just like health, are merely currencies in this struggle for legitimacy among opposing forces. That the attribution of information and misinformation is critical because there are perpetrators. And in many of these conflicts, if not most, those perpetrators are regional or global powers, with highly sophisticated technical capabilities backing local fighters for strategic purposes. And the ability to attribute and to identify perpetrators of misinformation, just like attacks on health facilities and health workers, is an essential tool that has always been utilized in global settings where humanitarian norms are being challenged.
Thank you. I don't know if Zulfi or Mike have anything else to add. I'm gonna, all right, let me move on to a question that is again in the Q&A that I think is important, and we've kind of come right up to the edge and talked about it a little bit, and I'm going to really open this up to whoever wants to. But the question is, could you address the issue of what seems like an escalation of sexual violence and gender-based inequities? Again, this is a long-standing issue, but it does feel, and maybe this is just perception, that this has gotten meaningfully worse in the last decade. I don't know if that's true or not, but I don't know if anybody wants to get us started on those issues.
I'll comment just briefly. We do a fair bit of research on this, and I think one of the phenomena, this has always been a feature of war, and so it is not, while it's not in any way normalized or should be the case, it's been a common feature of war and social disruption and violence. And it's also seen as a form of population control and a variety of other issues. I think what we've seen in the last couple decades is, most conflicts are intrastate, right? They're with non-state armed actors and asymmetric forces. So you've got very local, smaller forces, and then larger national forces, for example. We see it in the DRC and in many other places. And so wars are fought in communities and among civilian settings, and militias hide in civilian settings as well. And so there's just much more exposure, I think, to vulnerable populations, to militias, and to the effects and the ravages of war. And so, we have seen this sort of horrible escalation in rape as a weapon of war, sexual abduction, sexual exploitation, and this is not just in active conflicted communities, but in those disrupted communities like mining communities in the Congo, for example. It's just an escalated and to some degree exaggerated feature of conflict.
So I'd like to point out that this is not new, and I think it'd be unfair to blame it on recent conflicts such as Syria and what have you. This was the weapon of war used in Bosnia. And it happened in a very European civilized context as a weapon of war right in front of our eyes. And is still a major source of embarrassment for people who ignored it at that time. So unfortunately, this is a ground reality in many conflicts as another means or mechanisms of subjugating another population or groups of people. I think the default here should be that this is something that we must be aware of in all contexts, irrespective of honor codes and where they're happening. And therefore, in our mitigation strategies, in our efforts to particularly protect the rights and provide support to girls and young women, this should be very much part of the toolkit that both local and other agencies have operating on the ground. Now, having said this, this is also an area in which the maximum progress has been made over time in terms of development of guidelines and development of standardized approaches. So in taking this forward, it's very much important that we localize the training of local NGOs and make these culturally acceptable. What I've seen also in many contexts is just the blind application of some of the methods, tools, and training modules without necessarily engaging with local players in terms of how do you make this more relevant, how do you bring more people on board, and how do you not focus on things which are not necessarily an issue in many of these areas, such as in the Afghanistan-Pakistan context, one would probably not focus as much on the promiscuity part of things as to what happens through sexual and reproductive violence as a deliberate act. But I will make one final point on this, is that one of the recommendations that we made as part of the branch consortium is exactly getting out of these silos. The issues of sexual reproductive health and violence are also intimately tied to other needs of adolescent girls and boys also, which are completely hitherto ignored. Nutrition is one. I mean, we found devastatingly high rates of malnutrition, anemia in many of these populations. So it is important for us to develop more holistic packages that are meaningful, that do include the needs of not only young children under 5, but also school-age children. And that's the call that we made as part of the branch consortium, in that there is a need for a global look at our evidence-informed guidelines as to how complete they are, what are the gaps that we need to fill through appropriate research and implementation. And finally, as we monitor these, as we build our indicators list as to how we are measuring some of these outcomes, it's important to also be a lot more holistic than we are currently.
Yeah, great. Thank you. I don't know if anybody else wants to. So we have about 7-8 minutes left, and I'm gonna try to get us to answer one more kind of big picture question, and that is that when we talk about conflict, we often have this mental model of these short-term displacements of people who during that period of conflict, which might last 6 months or a year or 2, are going to be displaced, and then maybe they'll go back home in a different context. That is the mental model that all of you are fully aware is a inadequate mental model, to say the least. And when you think about, I mean, Zulfi, you were talking about the Afghanistan-Pakistan border, but the truth is, in so many places, these are generational effects, and people end up being displaced for generations. And it really begins to ask the question, what does it mean to be displaced for generations? One of the questions that somebody asked is, there's always been a challenge to develop infrastructure and long-term capacity in environments affected by conflict. I do wonder, with climate change, with other broader effects, how do we begin to think about addressing health needs, other social and welfare needs, of course, for populations where the chances are they're going to be there for a long time, and that you need to build long-term institutions, not short-term help. It's a hard question, but I think it's an essential one, because it gets us out of our mental model of short-term aid to help people through what feels like a fleeting conflict. I don't know if anybody wants to get us started on the question of what do we need to do differently if we're thinking about a population and saying this is going to be a long-term problem. Zulfi, you've unmuted, so I'm going to ask you to start us off. Oh, well, you may not have meant to unmute, but this is the downside of unmuting. Is I will mind.
So I feel pretty strongly, Ashish, that particularly in areas where conflict has been ongoing for a while, you need to very rapidly move from just a band-aid set of solutions to a much more integrated approach, which in the medium term, even if not long term, needs to rebuilding. So that's one of the development paradigms that we have been exploring in terms of how do you make sure that you're not just forever treating people in camps, and that you are also working with the local health system. The problem that we have is, if you do not have a semblance of governance or a process where the writ of law exists in some shape and form, that does mean that you have to work with whosoever is controlling a particular geography. And that requires sometimes engagement, which is not possible for many actors. But in my experience, and again, I come back to this varies in different contexts. It is always possible to look at something beyond the horizon of the next 1 month or 2 months or 3 months. It may not be very apparent when you move into an area where your immediate response is just basically to save lives and to make sure that everybody gets vaccinated. And so there are those priorities in an early stage of the conflict. But you very rapidly move from them to what is it that we can do and do with local populations and systems that exist that will allow them to look after things themselves with minimal support. That's one of the values of task sharing. I wouldn't call it task shifting; it's task sharing, and if to do it with the people who are embedded from that one community, you're not looking at therefore bringing in a health workforce that by definition will not exist in that area beyond the conflict. So I'm very keen in terms of seeing how we can put forward those models. It also means that all of the aid agencies have got to work towards that one particular goal. This is not something that can be done piecemeal. And it also needs to be done with an eye on some sustainability with financial resourcing. So nothing happens without finances. So finding some mechanisms, and you've talked earlier on about cash transfers and making sure that there are some conditionalities attached to that cash transfer in some ways in rebuilding services or allowing those services to exist in those areas. So those could be possibilities.
Great, thank you. Paul, long-term thinking and shifting towards more long-term thinking.
Thank you. Well, clearly, I would strongly support Zulfi's comments. And there are a lot of technical and political elements that are worthy of discussion, but something that relates to long-term planning, but also to the issue of sexual violence, is the emerging important role of women in positions of leadership in shaping and reshaping these strategies that we often in areas of conflict and displacement talk about the vulnerability of women, and that's important, but we need to recognize their strength in creating the protections and these long-term solutions. That voice is stronger now than it's ever been. The expectations from communities of women has never been greater. And the role of women, paradoxically, in many areas of conflict and displacement has grown stronger as traditional barriers to women's empowerment have fallen away. And it's critically important in this discussion and the global community both respect this emerging women's voice, but also provide it with the support it deserves.
Thank you for highlighting that, which I think is absolutely essential, and increasingly in so many critical global health issues, we realize that the importance of more women leadership and engaging women is a pretty central part of the solution. Because we're running out of time, I'm going to ask Mike and Stephanie to also, if you guys don't mind, just any last minute thoughts about thinking about these as long-term challenges and how that shifts the work of building health and health systems and resilience for what are becoming increasingly long-term problems, not fleeting ones.
So I'll
Mike. Oh, sorry, Stephanie first.
You go ahead.
I'll just say very quickly, I think we want to think long and hard about the role of storytelling and narratives in this, as we have consistently seen that if we don't, we have narratives that support violence and conflict or continue, instead of building resilience and unity, and like building a healthy information environment that can do that is just so essential. And this is like in the aftermath of this, traditionally, the leading, whoever had like the leading power would have control over the narrative, and that is no longer true. So the suppression system of narratives has led to more grievances and violence, and we can use that this system has broken open to actually see like how we can use reconciliation processes and narrative tools to build cohesion in those communities, as we've said, right, that have both the new people and the people who've been there for longer.
Thank you. Mike, you get the last word.
Thank you. I'll just comment that the transition from emergent relief that is life-saving and very much delivery-oriented to longer-term development requires two levels One is on the ground activities that translate to more long-term solutions, but really importantly are the durable political solutions that sometimes are far more divorced from actually the discussion of relief. So when you think about relief and development, many of the people who are in the circles of the diplomatic circles and accessing populations are not necessarily as closely aligned to the relief and development activities. And so having a closer partnership between policymakers and diplomats and the field-related efforts that are on the ground and going to be able to transition, I think is a crucial way of looking at longer-term, more durable solutions.
Great. Well, thank you all. And I have about a half a dozen more questions I wanted to ask, but we are at time. So I'm going to make just 30 seconds of remarks and then thank the panelists. You know, as I've been talking a lot about mental models, and there has been, for those people who are not deeply ensconced in this area, to think of conflicts as these short-term effects that have really negative effects on people's health, and then it gets better. And I think what you've heard today, and I really was struck by the term of de-development. I think, Mike, you might have used that, that it undoes years, often decades of progress in very short order. The way pandemics do as well, by the way, right? And, but one of the big solutions that has come out consistently in the last 75 minutes is about engagement of local leadership, building up local capacity, particularly around engaging women in leadership. And that becomes central for building health system resilience. It becomes central for fighting misinformation. It becomes central for really improving the well-being of societies. The indirect effects of conflicts are far greater than the direct, and the direct are bad enough. But what it also means that if we're going to take these issues on, that yes, we're going to need health experts, but we're going to need to do this by engaging a lot of other sectors of our society as well. This has been a really fabulous conversation. I personally have learned a lot. Thank you all for being a part of this. Thank you, Paul, for getting up early, for Mike and Stephanie and Zulfi. This was really terrific. Huge thanks to the organizers from Aga Khan and my colleagues at Brown. And thank you all for being part of this. Obviously, there are a lot of deeper issues that we still need to get into. And so we will follow up. This is not a one and done. We will have further discussions diving more into these things. But we could not have, I think, had a better discussion than with the four of you. So thank you all for being part of this. And have a great day, everybody.
Thank you all.